and welcome to this webinar session in honor of World Antimicrobial Resistance Awareness Week. Today's webinar is The Race Against Antimicrobial Resistance in Neonates, Insights on Data, Infection Prevention, and Stewardship. We are excited to host the webinar and hear from our speakers and panelists. We will have 3 presentations followed by a panel discussion. I am Katie Wilson, an epidemiologist in the International Infection Control Branch here at the US CDC. I will be moderating this session alongside Dr. Fernanda Lessa, who is Chief of the International Infection Control Branch. A couple of notes for everyone as we get started. French and Spanish interpretation is available for this webinar. In your bottom Zoom menu, click the globe icon to access channels for Spanish and French interpretation. If you have any questions for the presenters or panelists, please use the Q&A, the questions and answers button on your bottom menu to submit your question, and we will be answering those live throughout the webinar. If you would like to introduce yourself or have any questions about interpretation, or if you are having any technical issues, please use the chat function of this webinar. I will now turn it over to Fernanda to introduce our first session and speaker.
Good morning, everyone. Good afternoon or good evening, depending on where you are. Thanks for joining us today for this important webinar session. It's my pleasure to introduce our first speaker, Dr. Amelia Keaton, who is a medical officer within the CDC's International Infection Control Branch, where her work focuses on detection, prevention, and response to healthcare-associated infections in low and middle income countries. As a pediatric infectious diseases physician, she has a special interest in developing resources and guidance for neonatal care units and other pediatric healthcare. So Amelia, over to you. If you are speaking, Amelia, you are on mute.
Sorry about that. It took me a second to swap over. Are folks able to see my screen correctly?
It's not on presentation view.
Okay, 1 second.
Perfect. Thanks, Amelia.
Great. Thanks, everyone, and thank you for having me today. My goal for this session's for my presentation today are to provide an overview of the unique aspects of neonatal healthcare settings. And just for reference, a neonate for the purposes of this talk is an infant who is less than 30 days of age. I also hope to discuss global disparities in neonatal mortality caused by infections, and then review the epidemiology and impact of antimicrobial resistant infections. So newborn infants have a lot going on. All newborns, as soon as they're born, need to learn quickly how to breathe independently, receive appropriate nutrition, and fight infections with a very immature immune system that has not seen a lot of the organisms that they're coming in contact with when they first enter the world. However, fortunately for all of us, most infants that are born at term, which is on or after 37 weeks of gestation, handle these challenges with few or no medical interventions and do just fine. However, infants that are born either prematurely or with low birth weight or with other congenital health conditions face a lot more challenges that require many more medical interventions in some cases. So to begin, these infants tend to have an immature skin barrier, and that's why we use temperature-controlled isolates, such as the one shown in this photo. Second, they also have incomplete lung maturation, as well as central nervous systems, which impairs their ability to breathe independently. And for these reasons, we often see infants requiring invasive or non-invasive respiratory support. And in some cases, they develop hemodynamic instability. Next, we often see that infants that are born before a certain gestational age do not yet have the ability to feed independently. And so often they will require feeding in G-tubes or parenteral nutrition via a central or peripheral venous catheter. And then finally, these infants are often at a much higher risk for infection. And some of this has to do with the fact that maternal placental antibody transfer that typically occurs during the third trimester of pregnancy has not occurred yet. And so in addition to having an immature immune system as any other newborn would, they are also starting at a bit they have limited antibodies that they've received from their mothers. And so I know a lot of people who don't work in pediatrics or in newborn medicine often walk by newborn care units and get very intimidated. But what I try to remind people of is that infants in these units typically have the same risk factors for healthcare associated infections as older children and adults that are also receiving medical care, meaning that they have a weakened immune system because of critical illness. They typically have a compromised skin barrier. They have a lot of different caregivers. They typically require a prolonged length of stay, and they often have the presence of medical devices, all of which increase their risk for infection. Moving on to where these infections are most frequent, we know that mortality and morbidity from infections are highest in low and middle income countries. Approximately 99% of global neonatal mortality occurs in countries that are classified as low and middle income, with the countries in Africa and Southeast Asia being the hardest hit. Among infants that are born in a hospital in these settings, healthcare-associated infections may account for anywhere from 4% to over 55% of neonatal deaths, depending on the setting. And when we look at the pathogens that are causing neonatal infections and neonatal sepsis, we also see differences by the income level of the country in those pathogens, but also in mortality. So on the left, we have a figure that I've borrowed from a meta-analysis of the most common pathogens indicated in neonatal infections. On the left-hand side is the pathogen replication for countries that are considered high income. And you can see from this that the most common pathogens are E. coli, which is typically an enteric organism that may be acquired from mother or the environment. There's also representation from coagulase negative staph and group B streptococcus. However, when you move to those countries that are middle income or low income, you start to see a much larger proportion of these infections caused by gram-negative organisms, including Klebsiella pneumoniae. And when you look at the pooled case fatality rates among neonates that have these infections, low-income countries face the highest mortality rates at 25%, which is almost double what we see in high-income countries at 12%. Next, I want to share some data from the NEO-OB study on antimicrobial resistance in neonatal sepsis. This study was a prospective multi-country observational study where the researchers collected detailed daily longitudinal data in 11 countries across Latin America, Africa, and Southeast Asia. The figure that we see on the left is the frequency of different pathogen types in infants with diagnosed confirmed sepsis and how they evolve with each day of postnatal age. So starting on the left, again, we see a larger representation by E. coli. We see some gram negatives, but not as large of a percentage. But as the infants grow older, you again start to see a higher proportion of pathogens such as Klebsiella pneumoniae and Acinetobacter. Of the infants in this study, at least 62.9% had a gram-negative organism detected as their reason for sepsis. And the figures on the right here demonstrate the antimicrobial susceptibility profiles for these isolates. And so for here we're showing the 3 most common organisms that were identified as gram-negative infections in this study. I'm not going to go through and try to make you read the antibiotic names here on the x-axis, but just to note that the higher amount of dark gray bars indicates a higher level of resistance of that pathogen. So obviously Klebsiella pneumoniae and Acinetobacter have large levels of antimicrobial resistance in this population. Interestingly, though, E. coli, which is something that makes up a larger percentage of infections on the first day of life, has what we can see, those isolates appear to be somewhat more susceptible to antibiotics, which is interesting as these E. coli typically tend to come from mother at the time of delivery. Next, I'll share some data from the Child Health and Mortality and Prevention and Surveillance Network, which includes 7 countries, all low and middle income. So the initial analysis of CHAMPS data identified that initial analysis from the study identified Klebsiella pneumoniae as the most common pathogen in children under 5 and the second most common pathogen causing infections in neonates. Of 157 of 497 isolates from children with K. pneumoniae in the causal chain of death within this study, 84% were resistant to ceftriaxone, which is a commonly available 3rd-generation cephalosporin. There's also high levels of resistance to other antimicrobial classes, as you can see here on the right. Moving on to where these organisms may be acquired, I want to highlight some work from the Burden of Antibiotic Resistance in Neonates from Developing Society, our Barnard study. This is a very elegant network and elegant set of analyses. But in this particular one here, the authors were looking at the presence of antimicrobial resistance genes in the gut microbiota of mothers and their infants who went on to develop neonatal sepsis. I think what is probably most interesting to highlight from this is that over 50% of infants studied within this analysis were colonized with at least one extended spectrum beta-lactamase producing organism. And 1 in 5 infants was actually carrying the gene that encodes the New Delhi metallobeta-lactamase gene, which confers carbapenemase resistance. In many cases, these antimicrobial resistance genes were actually detected within the first 24 hours of life. And while some of that may be connected to transmission from their mothers, they also saw a large amount of genetic relatedness between isolates from neonates that were receiving care in the same unit as the neonates in the study, which indicates that there is healthcare transmission happening in many of these cases of neonatal sepsis. And that's important because that's where folks like us can step in and hopefully impact that high number. Next, I wanted to show a study that involved one large neonatal unit within a hospital in India. These data sought to understand the relationship between maternal, rectal, or vaginal colonization and environmental gram-negative colonization with bloodstream infection isolates among hospitalized neonates. So the black dots within this figure each represent a confirmed neonatal infection with the pathogen that's shown here at the bottom. To better evaluate the connection between these isolates, the authors also collected sink isolates from sinks within the unit. And this is important because we know that sinks and other water sources may be great places to are typically susceptible to colonization with biofilms with antimicrobial resistant organisms. And so the authors wanted to include this as a proxy for the role that the environment might play in these infections. And then finally, the lines between these dots indicate the number of single nucleotide polymorphisms that were identified between each isolate, and a lower number of single nucleotide polymorphisms indicates a higher degree of genetic relatedness. You'll notice here that there are no dots representing maternal colonization isolates, and that's because the authors of this study did not actually identify neonatal bloodstream isolates that matched isolates obtained from maternal specimens. However, the clusters that we see here indicated there was a high degree of relatedness between isolates collected from infants within the care unit, particularly among infants that received care within 30 days of each other. So we see tight clustering here with a sink isolate in the middle. There's also connection with another cluster of isolates that occurred among 3 different infants. And then each other each other grouping of isolates represents healthcare transmission within the unit as well. And what all of this means, I think, for the future is that antimicrobial resistance is changing the way that we approach empiric antibiotic therapy. So as a point of reference, the World Health Organization and many other professional organizations recommend ampicillin and gentamicin as the recommended empiric antibiotic treatment for neonates that are suspected of having infections. And the reason for this recommendation has multiple origins. I think one is that these antibiotics typically cover the organisms that we see in neonatal sepsis in high income countries. So things like group B strep, E. coli, are typically well covered by these antibiotics. They're also widely available and relatively cheap. However, a sub-analysis of data from the Barnard's network, which I mentioned previously, sought to look at how infants who received broader spectrum antibiotics fared against those who received the traditional regimen of ampicillin and gentamicin. And so the survival curve on the left represents the survival of infants who received each different antimicrobial regimen or combination. And this, again, are data that were collected from many hospitals across different countries in the world, and which is why you see different antibiotic combinations used here. So the ampicillin and the children that received ampicillin and gentamicin are shown here in the red bar, which unfortunately indicates that infants that received either pip/tazo-amikacin or infants who received the combination of ceftaz and amikacin actually had a much higher rate of survival than those who received that regimen. A few other antibiotic regimens were tried as part of this study, although those infants showed lower levels of survival. And so I think, although there may be multiple factors at play here, we are seeing a lower rate of survival now with infants who are receiving ampicillin and gentamicin. And the future of antimicrobial resistance is also somewhat scary because neonates and children typically are underrepresented in the antimicrobial trials that happen to try to identify new antibiotics that can target antimicrobial resistant organisms. So in terms of new antibiotics approved since 2000, we see that only 4 new antibiotics have been approved for neonates and 6 antibiotics for children over the age of 1, which is in comparison to the 40 other antibiotics that have been approved for adults. In looking at the global spectrum of clinical trials that are happening, there are many fewer clinical trials that actually are enrolling children or neonates, which means that if this doesn't change, we're going to have very limited options if we continue to see evolving antimicrobial resistance in this population. So I won't go very much into the different ways that we are trying to address neonatal antimicrobial resistance, as we have 2 speakers following me that are going to go a bit more into some of those topics. But in terms of kind of where we're looking these days, I think we know that we need better data on neonatal surveillance definitions and affordable diagnostics so that we can better diagnose these infections and compare data between different clinical sites and between different countries. Antimicrobial stewardship programs and smarter antimicrobial use in general is also something that I think will be important in the future. Infection prevention and control guidance targeted specifically for neonates so that we can interrupt that healthcare transmission of these organisms. A better antimicrobial toolbox with pediatric representation in clinical trials and evaluation of different dosing regimens for this population, I think is also critical. And then finally, I think another area that we often forget is that we may be able to tackle some of these infections by helping our infants develop a healthier microbiome. So things such as kangaroo mother care, which involves an infant spending more time skin to skin with their mother, and with the encouragement of breastfeeding can help with this. We can also help with a healthier microbiome by helping to maintain skin health in these infants so that they are not colonized with some of these organisms in the first place. So in summary, antimicrobial resistant neonatal infections disproportionately impact low and middle income countries. Colonization with antimicrobial resistant organisms occurs rapidly after birth, and organism relatedness indicates transmission from other infants and from the healthcare environment. And multimodal interventions, including infection prevention and control and antimicrobial stewardships, are necessary to protect these infants. I will stop there and I will pass it to Fernanda to introduce our next speaker. Thank you.
Thanks so much, Amelia. Thanks for that great presentation, and we'll hear more from you during our panel discussion. I am excited to introduce our next speaker. Dr. Famida Chowdhury is a medical epidemiologist with over 20 years of experience in pediatric medicine and public health. She is an associate scientist and project coordinator at ICDDRB in Bangladesh. Dr. Chowdhury leads research on antimicrobial resistance and respiratory infections, particularly among vulnerable populations such as hospitalized patients, pregnant women, and neonates. She has spearheaded over 40 major projects, including pivotal studies on AMR, Candida auris, influenza, RSV, and SARS-CoV-2. So with that, I will hand it over to you, Famida.
Hello, everyone. I think I'm audible, right?
Yes, looks good, and we can hear you.
Okay. So good morning, good afternoon, and good evening, depending on your time zone. I would like to thank the organizers for giving me the opportunity to present our research findings on critically ill neonates from Bangladesh in this webinar. So let me say it again. My presentation is on reductions in antimicrobial resistance in neonates through focused infection prevention and control interventions. I'm sorry, it's not moving. Is it moving or not?
It's not moving. Did you try clicking at the bottom?
Yeah, it's
there
okay
you go.
now. Yeah. So it is highly concerning that antimicrobial resistant bacteria are frequently causing sepsis in newborns in low and middle income countries. The Sustainable Development Goal, that is SDG, aims to reduce neonatal mortality to at least 12 deaths per 100,000 live births by 2030. However, these AMR infections are impeding progress in achieving neonatal mortality targets of the SDG, as you can see in the figure in the right-hand side. So colonization, why we are worried about AMR bacterial colonization? Colonization is the presence and multiplication of bacteria on or in a host without causing disease. and is concerning as colonization with AMR pathogens increases the risk of future infections with these resistant organisms. A recently published systematic review highlighted that neonates are particularly susceptible to becoming colonized with AMR pathogens, especially in the setting of hospital births. So today I'll be presenting findings from two studies. The first study, part of the antibiotic resistance in communities and hospitals, that is in short known as the ART study, focused on antibiotic-resistant enterobacterials among hospitalized neonates in intensive care units of a tertiary care hospital in Dhaka city, which is the capital of Bangladesh. Based on the interim analysis of this study, we conducted a second study to evaluate the impact of an in-depth IPC intervention in the same NICU, supported by the prevention and implementation teams of the International Infection Control Branch of the CDC. In my presentation, I'll be using the terms ESCRE, which is extended spectrum cephalosporin resistant enterobacterials, and CRE, that is carbapenem resistant enterobacterials. So the primary objective of this study is to determine the prevalence of colonization with ESCRE and CRE on and during admission among NICU patients, and also to estimate the incidence of infections with ESCRE and CRE among NICU patients colonized with ESCRE and CRE. So this was a prospective cross-sectional study conducted at the Neonatal Intensive Care Unit of a tertiary medical college hospital. Our target sample size for this study was 423, and rectal swab samples were collected on day 1, day 3, 7, and every 7 days thereafter for neonates admitted to the NICU. For laboratory testing, we plated rectal swabs on selected chromagar media, and rectal swab isolates and blood culture isolates underwent identification and antimicrobial susceptibility testing using the Vitek 2 system. So interim analysis from our first study revealed that you can see here that 37% of the 360 enrolled neonates were colonized with CRE at enrollment, while 74% acquired colonization after 48 hours of admission. However, you can see here that 16% of enrolled neonates remain CRE colonization free until discharge or death. Among the carbapenem-resistant enterobacterials, you can see here that Klebsiella pneumoniae accounted for 73% of the isolates, followed by E. coli, which was 33%. So, if we look back at enrollment, Klebsiella pneumoniae and E. coli accounted for 82% and 51% respectively. However, you can see here after 48 hours of admission, this proportion increased to 92% for E. coli and decreased to 30% for, 92% for Klebsiella pneumoniae and 30% for E. coli. So, and this findings highlights that there is a chance of carbapenem-resistant Klebsiella pneumoniae that, in short, known as CRKPN, circulating in the NICU. So given the high burden of CRKPN colonization observed 48 hours post-admission, we further analyzed colonization trends over time. We found a gradual increase of CRKPN colonization rate that was 31% on enrollment, 57% on day 3, 69% on day 7, 72% on day 14, and 73% on day 21. And this suggests that most neonates became colonized with CRKPN within the first 14 days of admission. So we analyzed the MIC values of these CRKPN isolates with different antibiotics and found consistent MIC patterns, suggesting the spread of same CRKPN strain within the NICU. So Our interim analysis of the first study reveals a persistent high prevalence of carbapenem-resistant Klebsiella pneumoniae colonization that is more than 73% among neonates. Over 58% of neonates acquire CRKPN colonization after 48 hours of admission. Clinical cultures confirmed infection with CRKPN, and their consistent minimum inhibitory concentration values were observed for various antibiotics across the most CRKPN isolates. And these findings suggest hospital-acquired transmission and infection with the same CRKPN strain. In this slide, you can see here that according to the WHO bacterial priority pathogen list, CRKPN has risen from 5th position in 2017 to the top position in 2024, highlighting its increasing global threat. So based on the preliminary findings of our first study, we conducted the second study with the primary objectives to assess the impact of IPC interventions that includes hand hygiene and environmental cleaning on CRE colonization and infection among NSU patients. And our secondary objective was to evaluate the impact of these IPC intervention on all-cause mortality among the NICU patients. So this quasi-experimental study was conducted in the same neonatal intensive care unit, enrolling 360 neonates in the pre-intervention phase and 421 neonates during the IPC intervention phase. During the pre-intervention phase, that is from July 2023 to January 2024, rectal swab samples were collected on days 1, day 2, 3, day 3, day 7, and at 7 days interval thereafter, depending on the neonatal NICU stay. In the post-intervention phase, that is from February to June 2024, twice monthly point prevalence survey were conducted, collecting rectal swab samples, and also biweekly evaluations of IPC practices were done. And blood cultures were performed as per physician's decision. For data analysis, for this study, we did descriptive statistics with Pearson cascade test for the comparison. The IPC interventions focused on training and monitoring healthcare workers on hand hygiene according to the WHO recommended 5 moments and also the environmental cleaning, along with providing counseling and motivation to mothers on hand hygiene practices before breastfeeding. The IPC team conducted structured and unstructured training sessions on hand hygiene for healthcare workers. It was like bi-monthly training sessions. So for structured training and for unstructured, it was frequent training based on the need, and also frequent training was ongoing on the hand hygiene. And also there was daily reminders of hand hygiene messaging were provided. Information, education, and communication materials as posters and leaflets were distributed to healthcare workers, caregivers, and also the family members. And also the continuous monitoring of hand hygiene practices was implemented. Detailed IPC training was conducted for healthcare workers on environmental cleaning, that is mostly for cleaning staffs. Simple visual guides were provided to cleaning staffs, categorizing cleaning zones into patient care areas, shared equipment, and also the common areas. And also the detailed cleaning schedules were developed and implemented. Beside that, ongoing monitoring of cleaning practices was ensured. This image highlights some of the patient-relevant surface areas for environmental cleaning. Cleaning with detergent and water was the essential first step before applying any disinfectant. And rest circle areas are disinfected with 5,000 ppm chlorine, and ash circle areas were cleaned with touchscreen compatible disinfectant. These images demonstrate environmental cleaning monitoring using glow germ in incubator, bed rails, and also monitors. So coming to the results, this slide shows the improvement in healthcare workers' compliance with hand hygiene and environmental cleaning practices during the IPC intervention at different time of point prevalence survey or PPS. Initial hand hygiene compliance was 13%, which gradually increased to 69% by the 12-point prevalence survey. Compliance exceeded 60% from the 6-point prevalence survey. Initial environmental cleaning compliance was 10%, which significantly improved to 87% by the 12-point prevalence survey, and compliance exceeded 60% from the 4th-point prevalence survey. Hand hygiene and environmental cleaning compliance showed a strong correlation with both experiencing a sharp increase following the intervention. So, initial low compliance improved markedly post-intervention, highlighting the effectiveness of these IPC measures. This slide showing the trend of CRE colonization alongside improvements in hand hygiene and environmental cleaning practices over time. Before the IPC intervention, you can see here that CRE colonization was high at 84%, while CRE colonization decreased to 60% after the initiation of IPC training, but fluctuations were observed at different time points. And the lowest colonization rate was 37% observed at 7-point prevalence survey, followed by an increase to 69% at PPS 12. The slide highlights the significant reduction in colonization with carbapenem-resistant organisms after the implementation of the IPC measures. Growth of carbapenem-resistant organisms, including enterobacterials, in Chrome-agar plate decreased from 93% to 81%. And Vitek confirmed CRE colonization dropped from 84% to 61%. If we look to carbapenem-resistant Klebsiella pneumoniae, it decreased from 73% before intervention to 52% during the intervention. And all reductions were significantly statistically significant. This slide is showing bloodstream infection and mortality before and after IPC intervention. Before implementing IPC measures, the bloodstream infection rate was 23%. While fluctuations were observed at different time points, a notable reduction to 4% was recorded by PPS 12. However, during PPS 2, the rate increased to 24%. Before IPC, the mortality rate per 100 admission was 17%. Although the rate showed variation, both increasing and decreasing across time points, it ultimately dropped to 14% by 12-point prevalence survey. The data indicates significant reduction in bloodstream infections with a downward trend throughout the IPC intervention period. However, the neonatal mortality rates did not show a statistically significant change, though showing a slight downward trend in mortality. So in conclusion, IPC interventions focused on hand hygiene and environmental cleaning successfully reduced colonization with carbapenem-resistant enterobacterial and bloodstream infections in the NICU. Sustained adherence to routine IPC practices is essential to mitigate the impact of antimicrobial resistance. However, additional strategies are necessary to identify hidden reservoirs and further limit the transmission of highly resistant pathogens in NSU settings. So this is all of our study findings. Now, I would like to express my gratitude to the US CDC and the Task Force for Global Health for funding these projects. Additionally, I acknowledge the co-donors of ICTDRB for their continued support, which makes our research efforts possible. Thank you.
Thank you so much, Fahmida. Great presentation, really showing us the impact of IPC, the environmental clean and hand hygiene, on reduction of broad infections among neonates. So let's go on to our next speaker, who is Dr. Fabio Araújo Mota. He is a pediatrician with PhD in biotechnology applied to child and adolescent health from the University of Pequeno Príncipe in Paraná, Brazil. He is currently the Assistant Technical Director of Quality Improvement and Research at the hospital Pequeno Príncipe, which means in English, Little Prince Hospital. So with that, I'm going to turn over to Fabio, and Fabio, I'm going to share your slide. I hope that everyone, can people see the slide or not yet? Can you all see the slide?
Yes.
Perfect. Over to you, Fabio.
Thank you. Okay. Good morning, everybody. I'd like to thank CDC for this honorable invitation, and especially for Dr. Fernanda Lessa. Today, I will present our national strategy for antimicrobial stewardship in neonatal and pediatric population and the translation into practice. Next. Next, please. I have no conflict of interest in this presentation, and my agenda will be the presentation of the 5 chapters of this guideline, beginning with the scenario presentation. Next, please. Next. Everyone who talks about this issue know this information published in 2016 by Jean O'Neill about the prevision of death in 2050 if nothing is done. But the most important information was what came later. Please, next. In 2022, The Lancet brought to us the following situation. Based on prediction statistical model, it estimated that there were almost 5 million deaths associated with bacterial antimicrobial resistance in 2019, including 1.27 million, 27 million deaths directly attributable to bacterial AMR. An investigation by United Nations Environment Program indicates that this could reduce the GDP by $3.5 billion annually and push 24 million people into extreme poverty over the next decade. Next, please. With this, AMR is on the 3rd place in the deaths rank in the world. Next. Next. Chapter 1 is structure of the antimicrobial stewardship program in pediatric and neonatology. Next. Here we can see the SWOT analysis of AMS in healthcare facility. Specifically in Brazil, in many neonatal and pediatrics units, we face this challenge. Next, please. About human resource, where no dedicated healthcare professional is available to lead the AMS team. About antimicrobial use and resistance data, where the supply of microbiology reagents is poor and the supply of antibiotic is poor. And about AMS activities, where healthcare professionals have competing priorities and little time for AMS work. Next. Next. Because of this, it's very important to count with support from top management and tactical level. And what is the role of strategic level? To give support of ASP policy, invest in the program with resource, and ensure economic sustainability. The role of the tactical level is important to organize management strategy, critically analyze indicators, and communicate it with senior management. Next, please. And yet, translate the clinical and economic results for strategic level and outlines and monitors the operation with stewardship team. And about the role of, please return, and about the role of operational group, it's important to perform antimicrobial management action and records and organize data. Next. To reach this result is fundamental to establish the model of the ASP governance structure, formed by strategic tactical vision, next, and operational vision. And inside of strategic tactical vision, we have ASP committee formed by this department, like pharmacists, therapeutic department, heads, quality and patient safety departments. And inside of operational vision, we have the ASP team formed by this professional, like microbiologists, nursing staff, pharmacists. And here, a highlight for this kind of professional that we call champion. Next, please. Next. Champion, next. Champion generally, no, sorry, return. Yeah, champion generally have a leadership profile and differentiate commitments in their unity so that they become a kind of advocates for judicious use of antimicrobials and the point of dialogue between the clinical unit where they work and the professional of the ASP teams, like neonatologists, hospital pharmacists, neonatology nurse, or infection control nurse, for example. Next. The chapter two is about the role of each service and effective participation of the members of ASP. Next. Here we brought the idea of antimicrobial chain of use. In the top of the iceberg, the action of the physician, that is to diagnosis of the infection and selection and indication of antimicrobial. But it's very important to remind that the bottom part of the iceberg contains these elements that can make antimicrobial not to work. They are elements linked with the medication, like dose or frequency of use, or elements linked with the patients, like diuresis, renal clearance rate, distribution volume, for example. Next. And to face this issue, it's very important to work in a multidisciplinary team. Next. The next step is to think about the ASP team composition. And in this document, we divide the team in operational team and supporting team. The operational teams, inside the operational teams, we have nurse, clinical pharmacist, infection or pediatrician with expertise in antimicrobial therapy, clinical microbiologist, and infection control professional. Next. After that, we specify the role of each professional that makes up the operational team. For example, role of the ASP pharmacist, like suggestion of dose adjustment. Next. Next. Record of data for indicators. Next. Antibiotic treatment time. And have conditional for doing, if well capable, assess empirical treatment. Next. About the role of the ASP microbiologists, it's important to give support about clinical sample collection and information on collection conditional, for example. Next. Next, please. Next. About the role of the ASP nurse, we can see next. Monitor patients, next. Plan and promote care for intravenous devices, next. Participate in immediate transition from intravenous to oral antibiotics, for example. Next. And last but not least, the role of the ASP physician, like leading ASP team, coordinate activities of ASP team, next. Next. And finally, to seek to maintain direct access to the clinical pharmacist, microbiologist, and nurse for the discussion and interpretation of cultural results. Next. Chapter 3 is about the particularities of newborns in the use of antimicrobials. Next. The first particularity addressed in our guide is about pediatric age group. Next. This classification is directly related to the dose to be prescribed, since the antimicrobial varies in dose according to age group. Next. The weight parameters is the most important variable in antimicrobial dosing because the prescription is given by milligram per kilo per day. Next. Pediatric patients frequently undergo weight fluctuation, especially in the neonate and infant age groups. Next. And more frequent weight measurements are recommended to allow for dose adjustments. Next. The next particularity is about PK of antimicrobial in critical ill pediatric patients. Next. And here we brought an example of sepsis or septic shock that leading to a serious condition with vasodilatation, leading to an increase in capillary leak with consequently hypoalbuminemia, with increasement of free drug and increasement of total volume of body water. Next. And decreasement of plasma concentration of hydrophilic antibiotic. Next. About the use of hydrophilic antibiotic, if patients have been using this kind of hydrophilic antibiotic like beta-lactamates, penicillins, or cephalosporins, it's important to remind that we need to calculate the dose based on the real weight and not the dry weight. In opposition, if they have been using lipophilic antibiotic like fluoroquinolones, macrolides, or tetracyclines, it's important to calculate the dose based on the dry weight. Next. Chapter 4 is about the strategy for antimicrobial implementation and management. Next. The first strategy brought in this document is about handshake antimicrobial stewardship model. Next. Handshake is a persuasive practice that includes prospective audit, education for rational use of antimicrobials, and multidisciplinary discussion, in opposition of restrictive practice that include pre-authorization or treatment times control forms. Next. Handshake is an expansion of the prospective antimicrobial audit strategy, daily review by the infectious disease specialist and the clinical pharmacist in 24 and 72 hours, where the performance and feedback, like intervention on antimicrobial, are prioritized by stewardship team through personal communication with the team, important to be face-to-face, for example, during clinical rounds. Next. The next strategy is about antimicrobial timeout. Next. The origins of timeout comes from the need for formal breaks during clinical periods. For example, in airplane checklists, surgical checklists, and nowadays, antimicrobial checklist. Next. And what is timeout and how to perform it? These are formal reevaluation of antimicrobial therapy and at intervals between 48 72 hours after the start of empirical antibiotic therapy, with strategic questions. In a nutshell, the timeout is a structured pause with the following question. Does the patient have an infection and responding to treatment? Next. Are the antibiotic and the dose correct and optimized? Next. Can the antibiotic be discontinued or de-escalated? Next. Does the patient meet the criteria for oral antibiotic therapy? Next. What will be the duration of the treatment? Next. Timeout contributes to the two main goals of the stewardship teamwork. The first, reducing treatment times and discontinuing unnecessary antibiotics. Next. The strategy 3 is about action to prevent antimicrobial resistance. It's important to remind that in 2002, the CDC published 12 steps for prevent antimicrobial resistance, and this publication masterfully brings together all the action to be developed jointly by antimicrobial management team and the infection control teams, bring together in a single scheme the importance of the interdisciplinary role of the physician, nurse, pharmacist, and microbiologist in combating bacterial resistance. This publication remains highly relevant since the same problems continue to exist within the intensive care units. Next. These recommendations were adapted for a neonatal intensive care unit by Patel in 2009, aiding guidelines focus on this population, beginning with the first step, like prevention infection with the use of vaccination. The second steps about remove catheters with when they are no longer needed. Next, please. The third steps about target therapy to the pathogen. The fourth steps about consult a specialist, consult experienced professional in treating infection in children and neonates. The fifth steps next about the use antibiotics correctly, practice correct use of antimicrobials. The six steps about use local data, know the overall antibiogram of its unit for empirical therapy. The 70 steps about treat the infection, not the contamination. Next, please. Next. And the 8 steps about treat the infection, not the colonization. Here is important to remind the importance of treat pneumonia, not the tracheal aspirate, for example, treat bacteremia, not the tip of the CVC connector, and remember that coagulase negative staphylococcus in a single blood culture sample with growth more than 48 hours may be contamination. Assess if the blood culture sample from the CVC is colonization when the peripheral blood culture is negative. Next. The 90 steps about use antibiotics correctly and know when to say no to vancomycin, cephalosporin, and carbapenems. The 10th steps is about discontinue antimicrobial treatment, for example, in surgical antimicrobial prophylaxis. 11th steps is about isolate the pathogens, and 12 steps about the break the chain of transmission. Do not allow sick visitors in the ICU and the NICU. The next. The last chapters is chapter 5 about indicators. Next. Here we brought a new indicators about classification of antimicrobial problems named PRET. PRET2 means Problem-Related Antimicrobial Therapy. Is a tool created by our group at Pequeno Príncipe Hospital, and there was no specific classification for problems with antimicrobials so far. This tool seeks to map the epidemiology of antimicrobial problems, provide opportunity for harmonizing records and comparing hospitals, if possible. Next. And this tool includes 17 primary problems domains and 69 subdomains. For example, next. Here we can see the systematization of this tool. Next, with primary domain, for example, prescribed dose, with its subcategory, like underdose based on literature or protocol, or overdose according to serum level, and its suggestion of pharmacotherapeutic intervention. In case of underdose, we need to increase dose, or in case of overdose, we need to decrease dose. The next example is about a necessary drug. Next, please. With its subcategory, patient without infection and use antimicrobial, or extend antimicrobial time without indication, with its suggestion of pharmacotherapeutic intervention like suspend antimicrobial, for example. Next. And here our last slide about the process and outcome indicators. In this guideline, we bring some suggestions about some process indicators like days of therapy or length of therapy, or some quality indicator like empirical antibiotic therapy consistent with local protocol, or dose adjustment for renal function, for example. And about some examples for about outcome indicators like clinical multi-drug resistance, or cost indicator like cost savings or cost avoidance, or days of therapy, for example. Next. These are our colleagues in the work group, and I'd like to thank for the opportunity to work with these amazing people. Here, Vanessa, Roseli, Mara, Beatriz, Marinei, Bianca, and Luisa, and Camila, and Dandiani. Okay, next. Thank you very much for this opportunity.
Thank you so much, Fabio, for the great presentation. It's nice to see the antimicrobial stewardship program guideline and all the indicators that you showed today for Brazil, but also more broadly for Latin America. So now I would like all the speakers and panelists to be on camera. We are going to start our discussion panel, and I have the honor to introduce our panelists. We have, as part of the panel, Twisha Patel, who is a PharmD, and the BCIGP is an infectious disease pharmacist at the CDC's International Infection Control Branch, where she focuses on her work on developing and strengthening antimicrobial stewardship programs globally. We also have a part of our panel, Dr. Angela Dramovsky, who is a professor of pediatric infectious diseases at Stellenbosch University and the head of clinical unit for the general pediatrics at Tygerberg Hospital in Cape Town, South Africa. She's passionate about patient safety with a focus on the prevention and treatment of neonatal sepsis in African hospital. Last but not least, we also have Dr. Deborah Tong, who is a registered pharmacist with postgraduate qualification in pharmacy practice and global health policy. She has a background in infectious diseases, clinical pharmacy, and is currently a technical officer working on antimicrobial stewardship in the Antimicrobial Resistance Division of the World Health Organization. So thanks all of you for joining today. And my first question is going to go to Dr. Deborah Tong. Can you talk about, based on the presentation, and you know that the AWARE book, the recommendation in terms of treatment for neonatal sepsis from the community is ampicillin and gentamicin, with the second choice being cephalosporin of third generation plus aminoglycoside. And we are seeing this increasing resistance in neonatal sepsis coming from the community. So is there a plan to update the AWARE book for the neonatal sepsis given the current epidemiology? And also, can you talk about all the WHO plans in terms of updating the antimicrobial stewardship toolkit?
Thank you very much, Fernanda, and thank you for all the presentations earlier today. As you mentioned, the AWARE book and WHO guidelines for neonatal sepsis are currently recommending ampicillin and gentamicin as first choice, or second choice being a third generation cephalosporin with amikacin or another aminoglycoside. So as an update, WHO is currently reviewing these guidelines, but for the time being, ampicillin and gentamicin still remain as first choice therapy, and the second choice still remains a third generation cephalosporin and amikacin. And the reason for this is because there's still not enough good quality evidence on the optimum antibiotic regimen to recommend, particularly in low resource settings and low middle income countries. So our first speaker, Amelia, mentioned the NeoObs prospective observational study that was conducted by Mike Sharland and all. So this was done in more than 3,000 babies in 11 countries over 3 years. And she did show some of the data from this study, but basically some key findings of that was that more than 1/3 of the babies that they had enrolled in this study had a history of previous intravenous antibiotic exposure, with many of them being exposed in the last 24 hours before enrolling in the study. And throughout this study, they also saw that more than 200 different combinations of empiric antibiotics were started in infants, showing that there's a huge variation in antibiotic prescribing practices globally and across different regions of the world. And basically, there was a lot of switching between different regimens, as well as escalation from narrower spectrum to broader spectrum antibiotics within the first few days and throughout the infant's treatment. And what we saw from that study and various others, that the most common pathogen was Klebsiella pneumoniae. And this was not only resistant to ampicillin and third generation cephalosporins, but also to beta-lactam, beta-lactamase inhibitors, as well as to carbapenem. So this makes it really difficult to actually formulate recommendations based on the antibiotics that we currently have and that many countries have access to. There's still very little data about the impact of AMR on mortality in neonates, and little information about how to account for all these confounding factors, as well as the heterogeneity in the studies that have been done and the consistent switching between different regimens of antibiotic therapy. So what we do need, and what is ongoing at this point, is more large-scale prospective trials that incorporate and allow for different study arms, not just comparing one to another. So there are some trials ongoing, like the NeoSep trial, which is evaluating the impact and efficacy of 3 different combinations of antibiotic therapy, including fosfomycin amikacin, flumoxif amikacin, and flumoxif fosfomycin. So while there's still currently not good enough good quality data to recommend something different, we do risk exacerbating the problem of AMR just by recommending broad spectrum antibiotics from the get-go, which are not backed by evidence. So we do look forward to the results of these new studies that are coming through in the next couple of years to inform new and updated recommendations for neonatal sepsis. Would you like me to continue with the toolkit update now, or would you like other members of the panel to go for their question first?
Yeah, so let's go back to the AMS toolkit then later, and then go to the next question. So Katie, over to you.
Yeah, so our next question, we're going to ask Angela to talk to us a bit more about strategies and advice you would recommend to colleagues in NICUs when thinking about IPC and AMR. Over to you, Angela.
Thanks, Katie. Good afternoon, good morning, everybody. Thank you very much. So I really enjoyed all the talks, but especially Famida's, and congratulations to all the work that they did in the unit in Dakar. I think the challenges are very familiar to anybody working in a low middle income neonatal unit. I wanted to take a step back just to conceptualize at what point pathogens and antimicrobial resistance elements are transferred to neonates to help shape how we think about preventing these infections. And so clearly it all starts with a pregnant mum. Often we think about infections in the neonatal unit as very polarized, early onset neonatal sepsis, typically thought of to be transmitted vertically from mother to child in labor and delivery, and then hospital-acquired infection, horizontal transmission from the healthcare environment, workers, equipment, surfaces, etc. I think what shocked me a little bit about Famida's data is that on day 1 of life, almost 40% of babies were already colonized with carbapenem-resistant Enterobacterales. So anything you do on the neonatal unit in terms of cleaning and hand hygiene is already too late. We need to be looking further upstream in our prevention efforts to make sure that we protect babies during pregnancy and delivery in those first 24 hours after birth. And there we need a whole package of care that speaks to prevention of preterm birth, maternal nutrition, careful management of maternal infections and antibiotic use, etc. And then really importantly, environmental and hand hygiene and device cleaning for a safe labor and delivery. Then once the baby is delivered and admitted onto your newborn unit, infections and pathogens that have been transmitted then colonize the surface of the baby. And then we need to move to measures that are going to protect the baby from colonization, going to invasive infection. And this is where all the traditional IPC measures come into place, as well as specific baby measures that some of the speakers mentioned to maintain a really strong barrier of the skin and the gut, which are the two biggest surface areas where bacterial pathogens can then invade into the bloodstream. And by the time you get to established infection, sepsis, and multi-organ failure, it's too late, and we've lost most of our babies at that point. So it doesn't matter the best antibiotics in the world, the most kind of appropriately tailored for your situation may be too late for many babies. So prevention will always be our first prize goal. And then just conceptually, to think about where do we need to work, where do we need to put our efforts. So the study that Famida described really is looking at that traditional package of infection prevention control measures, which try to prevent colonization of a baby with pathogens. But there are 3 other important areas I just want to highlight. So if you look at the top left, starting right at the beginning, we want to promote colonization with normal flora to outcompete the pathogens. And we can do this by doing really good essential newborn care with as early as possible institution of skin-to-skin care or KMC, ensuring that we give breast milk to as many babies as possible. There is an increasingly important emerging role for probiotics for gut integrity. And then what Fabio spoke to is so important. Babies that don't need antibiotics should not be receiving them. And those that need it, we need to try and stop them as soon as possible. And then again, moving on, looking at maintenance of skin integrity. There's many studies looking at emollient therapy as a way to improve the skin barrier. But we as clinicians need to do much better to prevent skin breaches and injury. So thinking of non-invasive testing for things like jaundice and doing better at securing IV devices. And then lastly, thinking specifically back to data. Data is power. So if you know your own neonatal unit, what pathogens are circulating, and you work with, as Fabio mentioned, your microbiologists, if you have them, or your surveillance teams at national level, you can look and decide what antibiotics are most appropriate based on your profile of pathogens. and then critically feed this information back to your neonatal unit staff and managers and parents, because only through working together as a big multidisciplinary team can we do better to prevent infections in hospitalized newborns. Thanks so much.
Thanks, Angela. I just want to take the opportunity here because I'm looking at the questions that are coming on the Q&A box, and I do think that's important. Maybe we can talk about two of the questions, because I do think that's something that we see often. It is hospitals NICUs being overcrowded. So sometimes 3 to 5 babies per bed, and I think one of the colleagues put on the chat, on the Q&A, what would be the recommendations when you have those overcrowded units and a lot of MGRO. And I think then the second question that maybe whomever wants to answer, if you can talk about what do you do on your NICU if you have a neonate with CRE? When do you discontinue contact precautions for that patient? So open to Fabio, Fahmida, or Angela, if you want to talk about your experience on your NICU.
Should I start?
I can go.
Go ahead.
Okay, just briefly, I can say what is going on in our NICU in Bangladesh, the study hospital where we conducted our study. As you have mentioned that our NICU is overcrowded, and sometimes it's occasional for a Dhaka Medical College NICU. We have to sometimes, have 2 or 3 bed for neonates in phototherapy machine, even for incubation as well. And if there is any CRE colonization, CRE infection is identified for a patient, nowadays, after we started our study, we have just have a separate, it's not a separate corner, I would say, just they separate the baby from the other babies, but still there is chance of contamination, having the transmission of the infection from that baby, because we can't isolate the baby in a separate room, because it's in the same room, but a bit different place. So this is the scenario in brief in our hospital, study hospital.
Thanks, Fahmida. Angela, I'm going to turn over to you if you want to talk about any strategies in this overcrowded setting, and also when do you discontinue contact precaution for CRE infected or colonized neonates?
Sure, I'll take the last question first. So there's not good evidence to guide, but we look at least 12 months. So we try to flag the record of that baby, because inevitably preterms get readmitted many times in the first year of life. And so we encourage, once a baby is readmitted, to reinstitute contact precautions for up to 12 months. And then we rescreen beyond 12 months to see if there's persistent carriage where possible. But I know that CRE screening is not widely available across most African hospitals. So, standard precautions should apply to every baby in every facility, and doing excellent hand hygiene, environmental cleaning will go a long way, even if you can't screen for particular resistant infections. And then the issue of overcrowding is a political, managerial, and a crying shame, because this is not something that clinicians and nurses at the coalface can do anything about. We try to provide the best care for the baby in front of us. And we absolutely acknowledge that overcrowding is detrimental to individual babies' health. And there is ample data globally to show that overcrowded neonatal units and under-resourced neonatal units, particularly with high patient-to-staff ratios, have poorer outcomes. That's non-negotiable. That is the truth. So we have to do much better advocacy as global bodies and as clinicians, caring for these vulnerable moms and babies, to demand the same. You would never put 3 adults in a bed. Why do you do it to neonates? Thank you. Over.
Great points, Angela. So let me go to Twisha with a question to move to antimicrobial stewardship. If you can talk about the CDC global effort on antimicrobial stewardship. And as you talk about the global effort, if you can address one of the questions on the chat was about monitoring the antibiotics that are classified as reserve antibiotics. Over to you.
Yeah, thanks so much, Fernanda. So I would say one thing that we very quickly noticed when starting to dedicate work towards advancing antibiotic stewardship globally is that there are many guidance documents that exist. There are many at the national level, there are many at the regional level as well. And so one thing that we wanted to do is not recreate existing guidance, but instead create some resources that really allow you to sort of take the guidance documents to the next step. And so I'm going to share my screen quickly to show you some of these resources. So first, of course, we have our core elements document that gives a little bit different perspective in terms of key principles towards developing a sustainable antibiotic stewardship program. This document has been around for many years, and it is available in both English and Spanish. And so, like I mentioned, we didn't want to recreate yet another document that is like this, and instead we've created something that accompanies our core elements document as well as WHO resources, and developed this global antibiotic stewardship evaluation tool. And this tool allows you to customize an action plan for your individual healthcare facility. And so it is organized by different domains, 5 different domains. You can see here. And essentially there are 66 questions, again, organized into 5 different domains. And there's a scoring system that we've developed to go alongside this tool. And what that scoring system allows you to do is really identify which domain your facility needs the most work to advance. And also, as many other presenters have mentioned, that communication from your healthcare workers to hospital administration as we advocate for more resources, et cetera, is important. And so the scoring system will also allow you to sort of share those data with hospital administrators at a higher level to, again, indicate where resources are needed. The other thing is that they're very detailed questions. So in very low resourced settings, we expect many of the answers to be no. And intentionally, we have created this document to be all-encompassing so that not to get discouraged, but to be able to identify where specifically you may be able to make improvements based off of your level of resources available. And then also the scoring will allow you to sort of track progress over time. So again, the tool is not intended to benchmark a healthcare facility. Instead, it is intended for the healthcare facility to advance their own stewardship program. So let's say the healthcare facility takes this at baseline. They identify many opportunities for advancement. They work on that in the coming year. They retake the tool. They should see an improvement in their score. Again, an easy way for them to track progress, as well as for them to communicate that with their hospital leadership. Again, we know in antibiotic stewardship that the more success we show and the more data-driven we can be, the more resources potentially will be allocated to building, again, a sustainable program. Part of this tool is monitoring and evaluation. And so remember, when we think about monitoring of antibiotic stewardship, we do think beyond antibiotics, right? So we also want to monitor use of various interventions and reporting to key players in the hospital. That may be to hospital administration, as I've mentioned, but also to microbiology and other healthcare workers across the institution. And so you'll see domain 5 is solely dedicated to monitoring and reporting of various metrics. And one of the metrics that was mentioned in the chat, I believe, was related to monitoring specifically of restricted antibiotics. There are two key antibiotic stewardship interventions that have the most evidence base to do this. The first is creating a restriction policy where prior authorization of use of those antimicrobials is necessary. So what this means is, let's say a clinician would like to prescribe meropenem. Prior to prescribing meropenem, there's a direct consultation with a member of the antibiotic stewardship team, and a discussion is had about the appropriateness of use of that agent. And that is what we call a prior authorization. And so the clinician, the prescribing clinicians needs approval before being able to prescribe that drug. Now, this is can be very resource intensive, right? Because you need somebody that is able to answer the questions real time. And the other evidence-based intervention is called prospective audit with feedback. And so in this scenario, the antibiotic stewardship team reviews a list of patients that are prescribed a target antibiotic. And then they review the clinical case as if they were managing the patient and decide whether or not meropenem is appropriate. Again, meropenem as an example in this case is appropriate for use. And then has a discussion with the clinical care team about alternatives, about duration, about dosing, combination therapy that may be necessary, etc. And so these are two practical ways to implement a restriction policy around the use of reserved antibiotics. Sometimes the easiest antibiotics to target, given that we expect the use of those antibiotics to be lower in the general population.
Thanks so much, Tuisha. I see that we have some attendees with their hands raised, but we are towards the end of the session, but I do want just to ask a question that's coming up a lot on the chat. It's related to MRSA colonization, and I'm wondering if one of you can talk about in your NICU, what's your policy once do you screen for MRSA colonization? If you do you try decolonization with mupirocin?
I can answer that from the South African perspective. So over the last 15 years in our neonatal unit, we've seen quite a change in the epidemiology of invasive Staph aureus infection. Initially very high rates. It was our second most common pathogen after Klebsiella pneumonia, and over 70% were MRSA. In the last 5 to 10 years, we've seen a shift with much lower rates of Staph aureus invasive infection, probably now our 5th most common pathogen, and a reversion to majority methicillin susceptible staph. We have not changed our policy in terms of screening for colonization, so we don't do screening unless there is a large outbreak of MRSA, and we don't routinely decolonize, only if we find an index baby who has a MRSA bloodstream infection, we decolonize that patient. And in the past, we did decolonize immediate contacts with both mupirocin nasally twice a day for a week and chlorhexidine gluconate body washes for a week. But in recent years, we've focused only on the index patient, good isolation in an incubator with contact precautions. Thank you.
This is wonderful. Okay, so we are at the end of our webinar. I really want to thank all the panelists and speakers, as well as all the audience who joined us today. Thanks so much, everyone, and hope that everyone has a good World AMR Awareness Week, and keep advocate to combat antimicrobial resistance globally. Thanks, everyone.